Good morning and welcome to our webinar on stroke warnings. We're going to get started shortly. We're waiting for more participants and we're going to get started right around 10 o'clock. Welcome. As I see more folks logging on, I just want to say good morning. And we're going to get started shortly. So I want to just say a couple of things while everyone's waiting. Ms. Rizzo is going to answer questions in the last 30 minutes of her presentation. And if you have any questions, you can just put them in the Q&A box and we will read them at that time.
Good morning, everybody.
Yep, and we're going to wait just another minute or two before we get started.
Yeah, I have 9:59. It's a bit early.
Hope everyone is having a great morning. And thank you so much for joining us this morning. And again, if you have any questions, we're going to answer them at the end of the presentation, and you can place those right in our Q&A box. And so it is 10 o'clock. Would you like to get started, or did you want to wait another couple minutes?
Let's wait a couple of more minutes. How many people are on at this point?
We have 6.
6. Okay, let's give them a few more minutes to
Yeah.
grab a cup of coffee or some water, and you make yourself comfortable.
Good morning. As you are coming in, we are going to get started shortly. If you have any questions, you can put them in the Q&A box, and at the last 30 minutes of the presentation, we're going to answer those questions for you. Good morning and welcome. So we're going to wait a couple more minutes before we get started, as folks are still entering the webinar. We're going to do a Q&A for the last 30 minutes of the presentation. And if you have a question, you can just put it in the Q&A box and Ms. Rizzo will answer it then. And so we're going to go ahead and get started.
Okay, excellent.
Thank you everyone for joining us this morning. We have Ms. Dana Rizzo, who's going to speak with us and present with us this morning. I'm going to let her introduce herself. We are going to have the last 30 minutes reserved for Q&A. If you have any questions, you can put them in the Q&A box and Ms. Rizzo will go over them with us all. And that's it. I'll turn things over to you.
Good morning, everybody. Thank you so much for being here. My name is Dana Rizzo. I've been a registered nurse for over 37 years, and my background is in medical surgical nursing, intensive care, and ICU and CCU nursing, as well as orthopedics and education. And I am a certified case manager as well, and I teach for Ali of George Mason University in Virginia, and the Turner Center, Wayne State University, and George Mason University. My contact number is dana.rizzo@singmail.com. I'm an area manager for Walton Woods Senior Living. And we're discussing stroke, and another name for stroke is cerebral vascular accident. Some people call it a brain attack, and they relate that to like a heart attack. So we're going to learn all about that today. Please use me as a resource. If I don't know the answer, I am very fortunate to work with some very skilled neurologists and physicians and pharmacists that can help us to get these questions answered. Thank you so much. And Nisha, thank you. And Jen as well. I'm going to minimize the thumbnail now. And here we go. Now, there are some objectives. We're going to just review the brain anatomy. We're going to talk about signs and symptoms of a stroke, identify the two main types of stroke, define a TIA, which is called a transient ischemic attack or a little stroke. We're going to discuss some of the behavioral symptoms that occur with strokes, and then identify post-stroke dementia symptoms, which can occur later after stroke occurs. Let's talk statistics. We know that a stroke accounts for about 1 out of every 6 deaths in the US, according to the Center for Disease Control in 2021. And someone dies every 4 minutes from a stroke in the United States alone, every 4 minutes. Each year, more than 795,000 people in the US have strokes, and about 610,000 of these are first or new strokes. We know that stroke ranks number 5 in all causes of death in the US. And in 2018, it caused more than 147,810 deaths. And we know we're going to start seeing more of that as we have this tsunami of baby boomers. Stroke is a leading cause of serious long-term disability in the United States. 3% of the males and 2% of the females report that they were disabled permanently because of a stroke. And by learning all of the information we're going to teach you today, we are going to prevent these disabilities, or if we are going to minimize them, so our quality of life is improved. Now, smoking, some of the risk factors for stroke are smoking. You shouldn't smoke anything. 8.7 million deaths occurred in 2019 because of smoking, and smoking has a direct relationship to heart attacks and strokes. Physical inactivity. We know that only 19 to 25% of Americans are physically active every day. And by physically active, I simply mean going for a stroll, going for a walk, a 20-minute walk every day. All of that is being physically active. You don't have to be a runner, a jogger. You don't have to play pickleball, although that's a lot of fun. But just going for a walk, going for a swim, going for yoga classes, all of those keep you physically active. We know that poor nutrition, being overweight and obese, has increased in the United States from 30% up to 42% in 2018. And a lot of that has to do with the inactivity that we have. And we're seeing a lot of younger people with obesity as well. Cholesterol, 38% of adults have a total cholesterol level greater than 200 milligrams per diluent or higher. And you want to try to keep your total cholesterol level under 200. We know that diabetes is on the rise, especially type 2, and we have 9.8% of American adults that are diagnosed with type 2 diabetes. We know that 37% of American adults have pre-diabetes related to inactivity and excessive weight. High blood pressure. They call high blood pressure the silent killer, because people don't even know they have it. If they're walking around with high blood pressure, not knowing that they have it. And according to the American Heart Association, you're considered hypertensive if your blood pressure is 130/80 or higher. 130/80 is like stage 1. And then if it gets to 140/90, you've got stage 2 hypertension. And then there's stage 3 and stage 4. But it's very important that 47% of the US adults have hypertension. And we, of course, are seeing more of that with increasing age. Now, what is a stroke or cerebral vascular accident? There are two main types of cerebral vascular accidents. And the first kind is called an ischemic stroke, and it's caused by a blockage. And the word ischemia means decreased blood flow. And remember, when you have a decreased blood flow to the brain, the blood is bringing oxygen and nutrients with it. So those brain cells, due to a blockage in a cerebral artery, that blockage will cause the death of those brain cells, just like it would cause the death of a heart cell. The first type of stroke is called an ischemic stroke caused by a blockage. I have pictures to show you. A hemorrhagic stroke is caused by a rupture of a blood vessel in the brain. Okay. Both of these types of strokes, ischemic and hemorrhagic, deprive the brain of blood, oxygen, and nutrients, causing the brain cells to die. Now, in an ischemic stroke, 87% of these strokes are ischemic. And ischemic means here is a cerebral artery right here, and they did a little cutout, a cross section, and it shows you that this artery has a cholesterol plaque buildup right here, cholesterol plaque. And a lot of times these cholesterol plaques actually bleed and they create a blood clot, which is what you're seeing right here. Well, that heart is pumping really hard to get blood through all of these arteries in the brain and really through every organ. But if the arteries are blocked because of cholesterol plaques and because of blood clot, the blood is returned. It stops there. It doesn't go to this area of the brain. And this is the area that is deprived of oxygen and blood. And it's called an ischemic stroke, because this purple area of the brain, these brain cells will die because it's not getting the blood supply and oxygen that it's supposed to be getting. There's another type of stroke called a cryptogenic stroke, and this is cerebral ischemia, like here, the purple, but it's of an obscure or unknown origin. And the cryptogenic strokes can be transitory, meaning that they're here 1 hour and then they're gone the next, and they're usually reversible. It's sort of like a warning that the big one may be coming. 1/3 of the ischemic strokes are cryptogenic, meaning the doctors cannot tell you what the cause is. They don't know what the cause is. But as you can see, the brain, this is called the cerebrum, is very vascular. You see these wonderful arteries everywhere and veins, and the heart is pumping that blood through all of these coronary arteries. And we really want to keep these arteries open and clear. We don't want an ischemic stroke. A hemorrhagic stroke, again, this is the one where the artery in the brain has actually leaked blood, or it actually ruptures and it breaks open. And the leaked blood puts pressure on the brain cells, causing increased intracranial pressure, which can damage the brain cells. If you'll, all of you, just tap the top of your heads, and you'll feel your bony skull, right? That bony helmet. That skull is there to protect the brain underneath it. But that skull does not enlarge when there's pressure underneath it. That skull stays the same size. It's not spandex or elastic. So that pressure, when you get bleeding underneath that skull, that pressure that it increases the intracranial pressure, that pressure is exerted downward, and that is not good at all. So we know that high blood pressure and aneurysms, which are balloon-like bulges in the arteries that can stretch and burst, are two examples of hemorrhagic strokes. So there are two types of these hemorrhagic strokes. One is called an intra, within the cerebrum, within the brain hemorrhage. It's the most common type, and it occurs when an artery in the brain bursts and it floods the surrounding tissue with blood, and it increases your pressures in your brain, increased intracranial pressure. There's a subarachnoid hemorrhage, and this is a less common type of hemorrhagic stroke, and it refers to bleeding in the area between the brain and the thin tissue that covers it. And I'll show you pictures. Now here's a hemorrhagic stroke, and as you can see, here is the artery, the cerebral artery that's burst, and it's actually leaking blood. Okay, and oftentimes this can be due to high blood pressure, that the blood pressure is so high that it exerts so much pressure on the inside of the artery that it leaks. And you can see how serious that is. Now, a subarachnoid, this is an aneurysm. These aneurysms, I saw quite a few patients in the intensive care unit and critical care unit with aneurysms that had burst. And these aneurysms they look like little, the size of peas, but they can become very large. They can, and they can occur anywhere. And these aneurysms occur because the arterial wall is weakened due to atherosclerotic plaques, due to excessive high blood pressure, and it continues to weaken the wall. And every time that heart pumps blood, it's exerting more and more pressure against this weak arterial wall, enlarging this aneurysm until it bursts. Now, a subarachnoid hemorrhage is where you get bleeding. The stroke area actually occurred up here, but the artery is actually leaking the blood in the subarachnoid space between the covering of the brain, which is the meninges, and between the brain itself. And this is called a subarachnoid space. Now, I just assessed a physician who had several falls on the concrete out in his driveway. And he had 2 subarachnoid hemorrhages, 2, and it was on both sides of the brain. And as I was chatting with him, and he had a diagnosis of mild dementia prior to the strokes, and he'd had other strokes, 1 or 2 small strokes in the past. Now, it was amazing because I spent over 2 hours with him looking for cognitive deficits. You know, I kept talking with him and asking him questions and, doing a screening on him, what they called a mini mental screening. But because this physician, and he was probably 79 and retired, but because he had used his brain so much throughout his life, he knew 2 languages, he knew Spanish, he knew English, he knew some French. He was always reading and researching. He was always very active and learning. And every day he went for a small walk, a short walk, and he had stopped smoking when he was in his 40s. But with all of that, it was amazing to see how well his brain had compensated for the damage, for the subarachnoid hemorrhages that he had. He had 2. He had 2 small stroke areas, plus he had mild to moderate dementia. And as I asked the questions, he was able to answer each and every one of them correctly. And I was over there for over 2.5 hours. But his secret, and what happened with him, is that he knew enough to get to the hospital quickly. We know that when people have either a hemorrhagic stroke or they have an ischemic stroke, that many of them think that the headache that they have is normal. They're going to take Tylenol and then they're going to go to bed. And really you have about a 3-hour window to get to the hospital to get life-saving drugs that are going to prevent the disabilities, permanent disabilities, and help you to recover. So that's why we're here today. And all of you are very wise to be here today, because if you learn the signs and symptoms of a stroke, you call 911 and we get you in and we get you treated. Now, a little brain anatomy. The frontal lobe of the brain, which is in the forehead, has to do, it's the pink, has to do with thinking, planning, problem solving, your emotions, behavioral control, and decision-making. So if the stroke has occurred in this area, these are the kind of symptoms or deficits you're looking at. If it's the parietal lobe, which is on the top of your head, it's blue. That has to do with your perception, your object classification, so that when you look at a glass, you can say glass with water versus looking at that and saying that's a car. Okay. Spelling and knowledge of numbers, and visual spatial processing. And visual spatial means that I know where my body is in space and how far I am from my computer screen or from my cell phone. Okay. The occipital lobe, which is yellow, is in the back of the head. And the occipital lobe deals with vision, visual processing, and color identification. And that's pretty darn amazing. That has to do with everything optical. Cerebellum is at the base of the brain, and they call this sometimes the little brain. And that has to do with gross and fine motor skills, like holding a pencil versus holding a mug versus holding a piece of artwork. It also has to do with eye-hand coordination and balance. Now, the temporal lobe, which is located right underneath your ears, okay, and that's green, has to do with memory and understanding, language, facial recognition, hearing, vision, and speech and emotion. And the brain stem is vital to life. The brain stem, we were created so that the brain stem is really in the middle of the body so that it's protected. It's protected from the vertebrae here, and it's protected from a lot of muscles and tissue and tendons here. Now, that has to do with regulating your body temperature, your heart rate, your breathing rate, and your swallowing. And it's critical for life. So as you can see in that hemorrhagic stroke picture, that hemorrhagic stroke occurred here. So you can see where it would be affecting probably 3 areas: the frontal lobe, the temporal lobe, the parietal lobe. If that cerebral artery was located here in the occipital lobe, then you would have vision problems. And that's what happened to my dad. I was living in Virginia, my mom and dad living in Florida, and I used to call them every day. And we'd have a cup of coffee on the phone and chit chat. And I called my mom and I said, "Hey, Mom, how are you? How's Dad?" And she said, "Oh, honey," she says, "what does it mean when you can't see out of one eye?" And I said, I said, "Okay." I said, "Who's having that symptom?" She said, "Dad." I said, "Okay." I said, "Where is Dad now?" She says, "Well, he drove himself to church." Now, that is not unusual behavior for my dad, but so he had lost peripheral vision out of his eye, his right eye. And yet he kept flushing his eye with water, thinking it was just a floater and it was going to go away. But again, denial. And of course, the peripheral vision, he said, "It's not enough to stop me." So he drove himself to church. So very calmly, I just explained to my mom that that is a symptom of a stroke and that she needs to call 911, tell the ambulance drivers where Dad is, and she should get up there and be with him so he doesn't get frightened. So she did that. She drove up there to the church. It was close. She preceded the ambulance. She was able to tell him that, you know, she spoke to me, and that loss of vision, little weakness of the left arm, things like that were signs and symptoms of a stroke. And of course, my dad says, "Oh, Dana, you know, she's always overreacting. This really isn't a stroke. I know it isn't." But he went to the hospital anyway. Thank goodness. They had him in ICU for about 5 days because he was having arrhythmias that were shooting little blood clots up to his brain. So they had to get his heart rhythm under control. And that was able to relieve the pressure on the cerebral arteries and stop the blood clots. And he was able to regain his vision, and the left arm weakness was also recovered. So depending on where that stroke is, that's where your symptoms most likely will show up. Now, there's something called a TIA, which is called a transient ischemic attack. Transient meaning it comes and it goes. Ischemic means it shuts down the blood and oxygen flow to parts of the brain, but it comes and it goes. So it's a warning stroke. People often call it a mini stroke. TIAs are different from a major stroke because the blood flow to the brain is blocked for a short time, usually no more than 5 minutes. However, it is a medical emergency, just like a major stroke, because we don't know if it's a TIA or if it's a major stroke. So we've got to get them in for treatment. There is no way of knowing if that person is having a major or a minor stroke, like a TIA. And the risk of a stroke within 90 days of a TIA may be as high as 17%, with the greatest risk of a major stroke within the first week of the TIA. If you suspect a stroke, call 911. Now, another time I was working, my aunt got us all tickets for a New Year's Eve party. And it was at an area church, and it was in a big community center with a band. It was really nice. And there were probably 150, 200 people there. And all of a sudden I hear someone calling from the other side of the room, "Help, help, nurse, doctor, we need help." Well, when I responded to that, there was an older woman, probably in her 90s, and she was sitting up, but she had collapsed. She had lost consciousness, and she was leaning over in her chair, completely unresponsive. So a group of us put her on the floor. I initiated call 911. I did the ABCs. Her heart was fine. Her rhythm was normal. And then her friend told me that her name was Jean, and that she had had an auto accident that morning, and she blacked out behind the wheel of a car. And she ran into one of these big yellow containers on the road. But she was a tough lady. She went to the hospital at that point, signed herself out against medical advice to come to the party that night for New Year's. And then again, it happened again. So my guess is she had a TIA early in the morning when she was driving, a transient ischemic attack, then had another stroke that night at the party. And she regained consciousness after 5 minutes. And the EMTs were there. I gave my full report. What my assessment was that I thought perhaps it was a TIA. She did have weakness of one side, right arm, right leg, but she woke up very agitated and embarrassed because she was on the floor. People were around her, and they were very concerned friends and family. But she did go to the hospital at that point and did recover, I heard later on, but she had a TIA in the morning, and that evening she had a pretty large stroke. So these TIAs cannot be ignored. You know, don't go to bed thinking, oh, it's just a mild headache, some mild weakness. I need to get seen. I need to call 911. Now, in diagnosing strokes, the doctors will often order a carotid ultrasound and imaging, because your carotid arteries are in your neck. If your carotid arteries have fatty plaques in them, atherosclerosis, then chances are the smaller arteries in your brain will also have it. Atherosclerosis doesn't attack one artery. It attacks all the arteries in the body. So it could attack your coronary arteries that feed blood and oxygen to your heart muscle, your cerebral arteries. It could affect the arteries that give oxygen, blood, and nutrients to your kidneys, to your liver, to your legs, anywhere. So this carotid ultrasound is giving them an image of how the carotid arteries look. They'll do a catheter angiograph if they want more details, where they'll inject a dye and then they'll go up with a catheter to take a look. They can do a cranial ultrasound or a head ultrasound. They can do a CT perfusion of the head to really see every cerebral artery. They're also going to do a blood, a lipoprotein blood test, and lipo means fat. So they're going to be looking at your cholesterol level, your HDLs, your LDLs, and they're going to be finding out just how much cholesterol you have, because that's going to help them identify how much plaque formation you have. They also do an MRI, which is the magnetic resonance functional test. And the MRI is important to give them more information. Now, where was the stroke? Remember the brainstem we talked about. At the brainstem, all of the motor nerves crisscross. So if you have the left hemisphere of the brain, which is my left side of the brain here, the left side of the brain controls the right side of my body. Okay. So if someone like my dad had left-sided weakness, I knew that his stroke had occurred on the right side. If you have right hemisphere stroke, okay, so my right hand is dominant, my right leg, I have the stroke up here, then the left side of my body is going to be weak. It's just the opposite side. Okay, so where was the stroke? Now, the left hemisphere has a lot to do with language. And we know that there are two motor and sensory regions of the cerebral cortex. This is called the cerebral cortex. And this is the frontal lobe. This is, again, the parietal lobe, the occipital, and the cerebellum. And then the temporal lobe. Well, there's two areas of the brain that have to do with language and speech. Broca's area, which is right here, and that's in the frontal lobe and part of the parietal lobe and a little part of the temporal lobe here. Frontal, temporal, a little bit of the parietal, has to do with the production of speech. So if your stroke is close to the Broca area, you're going to have trouble with speech post-stroke. If your stroke occurred further back, closer to the posterior portion of the temporal area and the parietal area, this is called the Wernicke's area. And this has to do with understanding speech, hearing it, hearing speech, and understanding and processing the words. So these two areas, Broca's area has to do with speech production. Wernicke's has to do with understanding speech because it's closer to the hearing centers, okay? The auditory control is right here. Now, the left side of your brain is supposed to be the very logical part of your brain, the left side. And in the left logical brain, you'll see a lot of people that are working IT, people in the sciences, in the math areas. You'll see people that are very technical. And but in the right area, you have your creative people. You have people that are the artists, the musicians, the photographers, you know, people that like creativity. But please notice that there is a bridge because most of us contain both right and left centers of the brain that we've developed. For instance, I'm very left brain. I tend to be very logical. I'm nursing all these years, science, all of that. But my creative side is that I love to do floral arrangements. I can't sing worth a tune, but I love creating floral arrangements. I have a daughter who was a lawyer who is very logical, but she loves photography. She loves music. She loves all of the arts. I have a son who is a Marine. He's left logical. And as far as being creative, he has a lot of, believe it or not, his creative side, he's extremely good in artwork and writing, creative writing. So it's just kind of interesting how we've developed, we have a dominant side, right or left. In a recent survey, when they asked people, what is the sign or symptom of a stroke? Only 40% of the people in the United States could identify, in a recent survey, 40% of the people could not identify a single symptom of a stroke. They couldn't identify not even one. And right now in Virginia, we have an initiative to teach people everywhere about what are the signs and symptoms of a stroke and what treatment to get. Just like when I started out in my nursing career over 40 years ago, people didn't know the signs and symptoms of a heart attack. And I was teaching CPR, and I was becoming an instructor's instructor for CPR. And we trained everybody in the world about what are the signs and symptoms of a heart attack and seeking help right away. With that initiative for strokes now is the same. We want everybody to learn what are the signs and symptoms of a stroke and what we can do to help ourselves immediately. So I'm hoping that with this initiative, we're going to be able to reduce this to maybe 1 or 2% or maybe 0%, that everybody's going to be able to identify symptoms of a stroke. Now, symptoms and signs and symptoms of a stroke, cerebral vascular accident, are sudden numbness of the face, arm, leg, especially on one side of the body. My dad had that. Sudden confusion, where they have trouble speaking or difficulty understanding speech. Sudden trouble seeing in one or both eyes. And it could be that it's just your peripheral vision, or it could be that the whole eye, you can't see a thing out of it. They could have sudden trouble walking, dizziness, loss of balance, or lack of coordination. They could have a sudden severe headache with no known cause. These are the signs and symptoms of a stroke. Sudden numbness, sudden confusion, sudden trouble seeing, sudden trouble walking, sudden severe headache. Now, you always want to remember that you have 3 hours. That's a window of opportunity to seek treatment so that we can preserve brain cells. Remember, we want to save brain cells so we don't live with disabilities. And there's an acronym called FAST, ACT FAST, F-A-S-T. If you think someone is having a stroke, assess them for the following. Look at their face, F, face. Ask the person to smile. Does one side of the face droop? You'll see this. They'll smile, and you'll see a drooping of one side of the face. Look at their arms. Ask the person, raise both arms. You'll see that one arm will drift down. Okay, ask them, can you raise your arms, please? And one arm will drift down. Look at their S, speech. Ask the person to repeat a simple phrase. You can ask them, what is your name? And they'll say, Thomas. And that would be Thomas. Their speech is slurred or very strange. Sometimes they can't answer your question. And remember to record the time. If you see any of these symptoms, call 911 right away, and record the time that the symptoms started. Was it at 2 o'clock at the barbecue? Was it at 9 a.m. when they woke up from bed? Okay, remember the acronym FACE. Look at their face, look at their arms, assess their speech, and record the time symptoms occurred. Call 911. The EMTs and EMS can begin life-saving treatment right in the ambulance. Never drive yourself to the hospital, never. And don't allow anybody else to drive you. You call 911 so that ambulance gets there and can begin treatment. Now, something that is important, I host a aphasia and stroke support group for a community center. And a couple were there, and they've been married for over 55 years. And he has Parkinson's, and he fell in his kitchen, but was able to recover. He took a fall, but felt himself fall and allowed himself to slide to the floor. So he had no broken bones. But his wife noticed that he fell because his left leg suddenly went weak. She noticed that his left arm was floppy, just floppy. She looked at his face, and she could see the drooping of the left side of the mouth. And she said, I'm calling 911. And he said, absolutely not. Just drive me to the hospital. They're very busy there. Just drive me. Well, she drove him to the hospital. They were triaged and put in the back of the line because they had all these COVID cases ahead of them. He was in the hospital for 4 or 5 hours, not getting treatment. Remember that if you come in by ambulance, you are triaged and you're number one, okay? There's no wait time. And by the time they gave him his medications to break up the blood clot that caused the stroke, it was almost too late. So he does have residual disabilities as a result of that. And to this day, he's apologizing to his wife. He says, you should have driven me. I should have listened. I should not have told you that to not call 911. Now, what do you do if you recognize a symptom of a stroke? Number one, expect denial. Nobody wants to think they're having a brain attack or a heart attack. Nobody, including me as a nurse. But if you recognize the symptoms of a stroke, you call 911 right away. Do not drive yourself or your loved one to the hospital or to church like my dad did. Note what time the symptoms started. Like my mom recorded that my dad got up at 8 o'clock to prepare for church at 9 o'clock, and his vision was gone. His peripheral vision was absent at 8 o'clock, but we don't know if it occurred during the night. You do not take baby aspirin. You do not take aspirin because if it's a hemorrhagic stroke, aspirin is an anticoagulant and it's going to cause more bleeding. You never wait to see what happens. Never wait to see what happens. Call immediately. Remember, lost time equals lost brain. And that's what we want to avoid. Lost time and lost brain. Now, remember, you're going to face denial because people are frightened. Like when my mom got to the church, she said, Dominic, I've spoken to Dana and we think that you're having a stroke. So an ambulance is coming. And my dad said, oh, why did you do that? You know, Dana overreacts. She's a nurse. She's always looking for the worst and symptom and all of that. But he really respected my knowledge. And so when the EMTs got there, they confirmed, they said, you know, Mr. Ziccola, you're having a stroke. We need to get you to the hospital. So off he went. But it was a good thing she called the ambulance ahead of time and they met her there because I think he would have been successful of talking her out of calling them. He was very good at that. Now, stroke treatment. You are assessed more quickly in the hospital if you enter by ambulance, just as I said. Treatment for a cerebral vascular accident or stroke begins in the ambulance. Do not drive yourself or allow someone else to drive you to the hospital. Everybody is well-intentioned, but call 911 and do not take the baby aspirin or any aspirin. If you get to the hospital within 3 hours of the first symptoms of an ischemic stroke, and remember, ischemic stroke is caused by a blood clot, they'll give you a thrombolytic drug, and thrombus means blood clot, lytic means dissolving it, and it will break up the blood clot called the thrombus. So thrombolytic. The best, most popular thrombolytic drug out there is called TPA, and it's called a tissue plasminogen activator, and it's a thrombolytic. TPA is given by IV, and it will actually break up the blood clot in the cerebral artery. It'll break up the blood clot if it's on your heart muscle. It's a really good drug. But again, we have to give it within 3 hours. That's your window of opportunity. They may try doing an endovascular procedure, which means that which is used to treat hemorrhagic strokes. And that's where they'll insert a long tube into the artery and through the leg or arm, and a small coil is placed to repair the damage and to stop the bleeding within the artery, the hemorrhagic stroke, especially if it has, if you have a section of it that has burst because of an aneurysm, or it's just leaking, they can put this coil in to prevent the leakage. Surgical treatment involves, for hemorrhagic strokes, they could be treated by surgery, and if the bleeding is caused by a ruptured aneurysm, they can actually put a clip there to also stop the blood loss, because we want to reduce the leakage, because that's increasing intracranial pressure, which also causes brain cell damage. What to possibly expect after a stroke. Now, the word is possibly. If you get to the hospital in time, we can really reduce your risk of these permanent disabilities. But you can expect that after a stroke, you will have paralysis or weakness on one or both sides of the body. You're going to have trouble with thinking, awareness, attention, learning new items, judgment, and memory problems. You may have problems understanding or forming speech, and that's called aphasia. You will have trouble controlling or expressing emotions, and that's because of the brain centers that are affected by the stroke. You could have numbness or strange sensations in your arms, your legs, your face, and anywhere. You could have pain, which is abnormal sensation, in your hands and your feet, where it feels like pinpricks, or it's fallen asleep and it feels numb. And the pain in your hands and your feet can worsen with movement and temperature changes. You could have trouble with chewing and swallowing if it was a big stroke that's affected some of the upper parts of the brain stem. You could have problems with bladder and bowel control. Again, that's very important in that motor section of your brain. These residual symptoms should be considered when you're creating your discharge care plan and goals of care with your case managers. Now, they have case managers, which are RNs and social workers that are in the hospital, which are there, and they have to see you and help you come up with a discharge plan. Are you going to outpatient physical therapy? Are you going to take physical therapy in your home? Are you well enough to go to an acute rehab facility, and does your insurance approve it? Or perhaps you could go to a skilled nursing center to get rehab. There's a lot of different options. They're going to, those wonderful case managers, social workers, and RNs are going to discuss with you the medication, your diet, lifestyle, all of those things. And your caregiver should be present so that you have an extra set of eyes and ears and someone who's going to be there to help you to comply with the doctor's plans. You might see some personality changes. They can have post-stroke dementia, and this can occur years after a stroke. And remember that this could be related more to the decreased blood flow to the brain, because you've got atherosclerosis of some of those cerebral arteries. So you have had a diminished blood flow and oxygen flow to sections of your brain. And that could be what's precipitating your dementia. The other thing is something called pseudobulbar effect. Pseudobulbar effect. This is a very real syndrome where people vacillate between being very happy, being very sad, being very quiet to being very loud, and they have no control over it. But they have medications that can try to control that. People often feel depressed after a stroke. I mean, who wouldn't? People feel anxiety because they're afraid another stroke might be coming down the pike. People sometimes get very agitated after a stroke. And that's what that woman did at that New Year's Eve party. When she woke up from that small stroke, she was fighting me and, pushing everybody away from her. And I was talking to her very quietly and very gently saying, I'm Dana, I'm a registered nurse. I'm here to help you. You're at the church. And we're getting you the help that you need. And she says, I am fine. Just get me out of this, off this floor. And she was, fighting. And of course, after strokes, people often feel anger, asking, why me? And these are all very normal emotional and personality changes that you see. So the pseudobulbar effect, you don't see it very often, thank goodness. And the post-stroke dementia, you don't often see until many years down the road. Recovery from stroke and aphasia. Now, there's a spontaneous recovery period, and this is a period of rapid recovery of symptoms in the first few weeks to about 6 months after a stroke. And that's all wonderful. And when I was a director of an acute rehab facility, hospital, I was amazed. We would get people in that had massive strokes that they were coming in on a stretcher and they couldn't even lift their heads off the pillow. Yet after 2 or 3 months of PT, OT, occupational therapy, speech therapy, physical therapy, nursing care, we were amazed at the recovery that these people had. They walked out with a cane. Sometimes it was a quad cane with 4 feet, but they were walking nonetheless. Long-term recovery, research has shown that recovery continues indefinitely. That's why it's so important after a stroke or aphasia that you contact the Turner Center, because Jen Howard is there and she will point you in the right direction of getting the support groups that you need. There are sliding scale groups. They're 501Cs, not-for-profit support groups, where they'll provide speech therapy, a continuation of speech therapy, and into an IT help, how to use a telephone, so that these people can resume their normal lifestyle. For one lady, after having had a huge stroke, for this one sweet woman, her big goal was to be able to speak and to go to Starbucks independently to order her coffee. And it was a very complicated coffee order, very specific. And that was one of her big goals. And she reached it. It took her about a year, but she reached it. But the speech language pathologist would walk with her to the Starbucks, which was about a block away from the support group. And they practiced a couple of times a week ordering what she wanted. It went very, very well. Some therapy options are inpatient acute rehab And inpatient acute, the word acute means you're going to get 3 hours of therapy a day. You're going to get physical therapy, occupational therapy, speech therapy, and nursing oversight. 3 hours a day for therapy. And this is where you go to an acute rehab hospital and you stay. But you have to be able to tolerate 3 hours of therapy a day. It is covered by some insurance and not covered by others. And you must meet the criteria for admission, meaning you agree to work hard 3 hours a day. And they're going to break it up. They're going to give you an hour of therapy in the morning, PT, maybe you get to go back to your room and rest, and then they'll pick you up an hour later and you go for an hour of occupational therapy. And then maybe right after lunch, you have speech therapy for an hour. They break it up because 3 hours solid would be hard for anybody. Pre-authorization is required because it's very expensive. They charge Medicare A and B and your secondary insurance, and it's very expensive. So you want insurance to cover it by all means. Your second option would be in inpatient acute rehab. You're only going to be there for maybe 2 weeks, 3 weeks at the most, because insurance has really compressed benefits. In a skilled nursing rehab, SNF, skilled nursing rehab, it's less intense therapy. You're getting 1 to 2 hours of therapy a day, 6 days a week. They extend it over 6 days, not 5. Often skilled nursing rehab facilities are pre-authorization is required. It is covered by insurance. And the first 20 days are covered at 100% by Medicare. But from day 21 to day 100, there is a copay of about $276 a day. And that's where, if you have secondary insurance, they will help pick up that copayment. But again, skilled nursing rehab facilities will keep you about 20 days, and that's about it. You have assisted living, senior living options called an ALF, assisted living facility. And we offer, like Walton Wood, we offer PT, OT, speech therapy once a day for about an hour, 6 days a week. And there is, these sessions are held right in the community. So the room and board in an assisted living community is not covered by insurance, only the skilled services. So Medicare and your secondary insurance will cover physical therapy, occupational therapy, speech therapy. If you have long-term care insurance, it will cover often all the skilled services. Many assisted living senior communities offer respite stays. And I know that respite stays, for instance, we have a retreat program at Walton Wood in Michigan where people can stay 30 days, 60 days, or 90 days. And it's wonderful. And you rent the apartment month to month. There's no buy-in. So that's always a very good option until you're really well enough to go back home, and you'll get nutritious food. Your medication will be delivered to you. You'll get assistance with morning dressing, afternoon dressing, and activities of daily living, and in the evening going to bed dressing. There is also an option of going discharging home with home therapy. If you're discharging home with home therapy, Medicare will cover it, and they can provide PT, OT, and speech therapy. And they usually come in every other day. You'll have a physical therapist Monday, Wednesdays, and Thursdays, for an example. Occupational therapy Tuesdays and Thursdays. And a speech therapist will come in 1 or 2 times a week. The RN is there only for oversight. She may be there to open up the case, what they call open the case, do the initial intake assessment. And you'll see that RN maybe once a month. And again, insurance covers it, but they only cover this for about 30 days. But your doctors, if the home health care company can go back to your doctors and get a second order that says continue home therapy for an additional 30 visits, so that it gives you, a span of about 2 months or 3 months. And sometimes we have to be pretty assertive with these insurance companies. As a certified case manager, which I am, I've always advocated very strongly for patients, as they all do. Outpatient therapy is another option, and this can be done in a clinic or in a center. And but you need a designated driver. You will make appointments and have designated days when you have to go to that clinic or center for physical therapy, occupational therapy, and speech therapy. It is covered by insurance, but usually there is a small copay, and you must have your own transportation to and from. And don't miss an appointment, because if you do, they charge you a penalty fee. Now, strokes linked to dementia. We know that only 1 in 4 people who have had a stroke will go on to develop signs of dementia. Only 1 in 4. Vascular dementia, which is the one that affects all of the blood vessels in the brain, is more common in older people, because as we all get older, we can have more cholesterol plaques forming unless we really modify our lifestyle. With strokes, the risk of vascular dementia increases with the number of strokes you've had over time. So the more strokes you have, that's telling the doctors that you've got more than one cerebral artery that's occluded, that's blocked by fatty plaque. You have multiple, okay? So we can expect more problems down the road. So signs and symptoms of stroke related to dementia include memory loss, especially not able to remember recent events, like what we ate for breakfast this morning. They can have inattention or poor concentration and difficulty following instructions. Like you could say, Jim, let's go out. Can you please put your shoes on and we'll go to the grocery store? And that's too much information. He heard grocery store, put on shoes, but he's getting it all mixed up. They have difficulty planning and organizing tasks. Jim might try to leave without his shoes on, okay? Difficulty planning. They have general confusion. They may start to wander and get lost in familiar surroundings, and they may show poor judgment. Okay, summary of what we have discussed today includes the 2 different types of strokes, hemorrhagic and also ischemic strokes, signs and symptoms of a stroke, how to act fast. We're going to look at the face. We're going to look at the arms. We're going to assess the speech, and we're going to record the time symptoms started fast. We looked at risks for having a stroke, prevention of strokes through lifestyle changes, never smoking, controlling weight, controlling stress, daily physical exercise. We talked about treatment of strokes, getting to that hospital via 911. We've discussed behaviors seen with some stroke patients, and we discussed goals of care and discharge planning considerations and options that you have. Now, as I talked about stroke support groups in Michigan, Turner Center offers stroke support groups. They have just so many options for you. The Turner Center is just amazing. And there's also a Spice of Life stroke group. And this is in Detroit, Michigan, but and there's their number. But we also have a family and client support group. And this is at the Novi Center in Michigan. And it's the Rehabilitation Institute of Michigan, which is renowned for the quality of their care. Now, these are some of the resources I use: the American Heart Association, the National Institute of Neurological Disorders, et cetera, et cetera. And this is one of my beautiful Walton Wood communities. This is Walton Wood Royal Oak. You can see how gracious and beautiful it is on the inside. And this is my contact. This is another Walton Wood. My name is Dana jen.rizzo@singmail.com. And you can call me on my cell phone if you ever need me as a resource. And now we're going to open it up for questions. Anonymous attendee, Jen, the chat has been disabled. I am new to Mid-Michigan. How do I attempt to locate the proper stroke center for treatment? I do not necessarily desire to wait for the EMS service if I can listen to my body. Okay. I will tell you that I know you're new to Mid-Michigan, but if you have got the best stroke center is the emergency department. The emergency department has the TPA, thrombolytic drugs, to initiate and to help with stroke management. After the crisis is averted and they've got you stabilized, then they will talk with you about where to go for rehab. And that's where you have all of your choices, whether you're going to go to an acute rehab center that specializes in stroke recovery. If you're going to go to a skilled nursing facility that specializes in stroke recovery, are you going to go home with home health? Are you going to go to an assisted living community for 30, 60, 90 days to get therapy there and to have that oversight? But again, your first action should be to call 911 and to get into the hospital by ambulance to get treatment started. That's your first step. Is this presentation recorded for future review?
Yes.
I believe that it is. Yes.
Yes, it is.
Okay, thank you, Nisha. When considering post-therapy, what is a better choice, infrequency or intense therapy? I came from an acute hospital, intensive care unit and critical care unit, and then I went to an acute rehab hospital. In the acute rehab hospital, if you can tolerate 3 hours of physical therapy a day and occupational therapy and speech therapy following a stroke, if you meet their criteria for admission, and if your insurance will pay for it, I would say go for the more intense therapy. I would say select acute rehab. That it will give you the 3 hours of therapy a day. Remember that window of opportunity, you're there for usually 2 to 3 weeks, and they can really get your blood thinned enough. They can get your the paralysis and the weakness. They can start working those muscles, tendons. They can start, speech therapy will start working with your neurons in your brain to get them woken up so that they can, you can begin the recovery faster. After the acute rehab period of maybe 2 to 3 weeks, if your insurance will allow it, then opt to go to the step down skilled nursing facility, because a skilled nursing facility can keep you an additional 20 days with physical therapy, occupational and speech therapy, about 1 to 2 hours a day. So it's kind of a step down, but by then you're ready for it because you're pretty tired from acute rehab. And then after acute rehab, skilled nursing facility rehab, you can go home with physical therapy. And that will give you a good, probably about 3 months of coverage. And then even after home physical therapy, you can get yourself into support groups that will continue to work with you on speech, social engagement skills, all of those wonderful things that support groups do. Okay, any other questions? Any other questions, please?
No, that seems like it's it.
Okay, I want to thank all of you for being here and for your wonderful questions. And I hope to see you again. I believe I have something else set up with Jen Howard in September and with Nisha. Have a lovely day and a good week. Thank you very much.
Thank you, Dana. Thank you, everyone, for attending.
Thank you. Bye.
Bye.